On behalf of the Society for Advanced Bronchoscopy, thank you, Dr. Bedi, for providing us with the next presentation. Dr. Harmeet Bedi is a clinical assistant professor and director of interventional pulmonology and bronchoscopy at Stanford University. He founded the cone beam computed tomography guided bronchoscopy program at Stanford in 2019 and would like to share his perspectives after 100 CBCT cases. He has multiple research interests within the realm of bronchoscopic device innovation and CBCT-guided bronchoscopy. Dr. Bedi.
Thank you very much for the introduction. I wanted to thank the SAB for hosting this venue, and I'll go ahead and begin. I was going to be talking today about new perspectives with cone beam CT, the first 100 cases that I kind of went through and wanted to share my experience. I have no conflicts of interest to disclose. I was just going to cover briefly on how to start a cone beam CT program and then talk about the first case and then going through from 10 to 100 and then finishing off with the future of cone beam CT. So I get this question a lot about, how do you get a cone beam CT program up and running? And honestly, it's a very large challenge to kind of, take on. But I broke it down into a couple of categories that I felt really helped me get up and running. First of all, is to start off by studying the landscape. Finding out within your institution, where are the cone beam CT scanners actually located? Are they located in a cath lab, in radiology and such? What brand and capabilities do the machines have? Some institutions have very old machines, some of them have new. So it's really important to find out what type of machinery you can even go after. Find out which specialties currently utilize these machines. They tend to be usually interventional radiology or vascular surgery or interventional cardiology. But it's good to kind of know which players are involved. And then this is very important to go through the schedule of all these rooms and try to find out, which machines are being used, which machines are actually being used for cone beam CT purposes. Are they just being used for fluoroscopy or not? And then identify which members are present on the cath lab committee. This tends to be a committee in the hospital that has oversight over the cath lab, over the rooms, over the machines. So it's really it's a really good task to kind of go through that and find out if actually any physicians or administrators that work on that team. Next is to kind of to identify the best disguise of how you can get into your cone beam CT room. Is there a way that you can get your research translated over there? Maybe something like testing the accuracy of an existing device or a tool that you have. Maybe you can just go under just being straight up and saying, hey, I want to explore cone beam CT bronchoscopy and see if there's a venue for you there. Or even bring up something like, hey, we're considering purchasing a robot. We're also looking at access to cone beam CT and seeing maybe what's a good fit for you. And then this is really important to start leveraging your contacts. Do you have an IR, vascular surgeon, or cardiology colleague that you have a great relationship with? Is there somebody in the hospital administration that you've worked with quite frequently that can be a great advocate for you? Or can you partner with somebody from thoracic oncology? As IPs work commonly with our thoracic oncologists, is there somebody from surgery, from radiation oncology, from med-onc that can help build a program with you? And then lastly, establish relationships with the cone beam CT staff. Work with a rad tech that works in these rooms. Learn about the room, learn about the machines. I can tell you personally, I had a lot of great experience of just learning the inner gossip of the cath lab just by hanging out with the rad techs and finding out what type of politics exist, which physicians like which rooms are underutilized and things like that. And I always say that the wine bottles, Amazon gift cards can go a really long way in this situation to kind of get you in the door. Your ultimate goal is really, can you perform 1 to 2 cone beam CT cases? Because once you do that, you're finally in. Now it's about staying there. So, the first case preparation is going to be the most important. It's going to be probably one of the most challenging episodes for your practice ever. So you really need to put in a lot of time and effort to kind of get up and running. You really want to plan to go observe and get team education. Me personally, I flew out to Krish Badra's place out in Tennessee just to watch him do a couple cases. I already had a lot of experience with animals, but I wanted to see, how these cases are performed on patients. You want to look at room layout and logistics, anesthesia, where's the machine going to go, things like that. Learning augmented fluoroscopy if your cone beam CT scanner is capable of doing that. Talking about the procedural actual workflow of how the case is going to go from induction to extubation, and then come up with some contingency plans on what happens if you're unable to get to your target. What do you do if this situation arises and such. This is a picture of our cone beam CT room. This is OR 8 at Stanford. This is a hybrid OR that has the Philips Azurion machine with lung suite on it. And this is where we do all of our nav cases. As I was talking about the room layout, where's your tower going to go? It depends on where your C-arm is positioned. How are you going to hold your bronchoscope? You don't really have that problem if you have a robot, but if you're using a flexible scope like we do, you want to get a bronchoscope holder. And then on the right-hand side, you can see what it looks like when we're actually actively doing a case. Here's another picture of me and my team, us performing a cone beam CT case, and we're all directed towards a monitor that's out of view in the picture currently. For anesthesia, we always use a number 9 endotracheal tube. We use TIVA for our anesthesia. We use a ventilator protocol that's been adopted from Krish Badra's paper, but we use higher tidal volumes, an FiO2 of less than or equal to 60%. We try to keep the PEEP at around 10 to 15. We try to raise the PEEP for lower lobe targets. And then we use lung recruitment maneuvers, 20 to 30 centimeters of water with an APL valve for 30 seconds times 4. That's done immediately after the patient is intubated. That's really to prevent any atelectasis and make sure that we start with a nice, gorgeous CT scan. And then we use breath holding during each CT spin and during navigation, as well as biopsies. So if our PEEP is set at 12 centimeters of water, we'll do a breath hold at 12 centimeters of water. And then, we'll do a spin or I'll navigate at that setting. For navigation, I'm not going to really go in depth in this because the purpose of this is really to cover kind of the progression of 100 cases. But a couple of things I just wanted to touch on. You can use this cone beam CT scanner with your existing navigation platform. So for users that already have a platform, I would strongly recommend using that with your CT in the beginning, as well as using augmented fluoroscopy. And an example of that is called Lung Suite with Philips, which can project your target onto fluoroscopy while you're navigating. But ultimately, what you want to do is you want to use multiple X-ray angles to do your navigation and to do your biopsy. One of the cardinal rules of radiology is that one view is no view. So you like to have confirmation that you're in the right location by having a separation. So coming from the right, coming from the left, and you want to have separation by approximately 90 degrees. Once you're in line with your target, that's when you can put your needle out and then do a sweep with it to kind of see, is your needle staying within your augmented fluoroscopy target, and then doing a CT spin at that portion at that time. And the whole purpose of the CT spin is to verify that you have tool and lesion, also known as TIL, because ultimately that's what you're using cone beam CT for, is to really prove that you're biopsying a target, and you can confirm that with your CT. So you really want to utilize this function. And if you don't get tool and lesion confirmation, you have to study what adjustments you want to make, and then potentially redo your augmented fluoroscopy, and then do another spin eventually. And then you re-navigate, and this cycle goes on until you successfully biopsy your target. As far as the first 10 cases go, you really want to have your team available. So if you have an MD partner, you really want them to be present. You want an experienced rad tech that really knows the machine inside out, that has a lot of experience there, a person that you feel comfortable with. And you definitely want to have a technical representative from the companies, having your Philips rep, for example, come by for your first 10 cases so that they can, he or she troubleshoot your cases for you. In my case, one of my interventional radiology buddies, who's a very close friend, joined me for my first 13 cases. And he basically, was guiding me through the cases on how an IR would do these cases. And I learned a tremendous amount through that. I did my first 10 cases using the Super Dimension platform because that's what we were using at Stanford earlier. I stopped with low risk patient population because I wanted to make sure that I got through the cases safely without any trouble. Because we don't work in a cath lab, any negative outcome that happens there is gonna get a lot of attention. So you want to make sure that you get through these 10 cases smoothly. I was very selective on the targets. I wanted to go after targets that I could successfully get that were easier, and I even did a few node positive cases just to make sure that I don't miss. And then most importantly, you're gonna have to put in work during these first 10 cases. This is a very unnatural type of environment for interventional pulmonologists because we're so used to flexible scopes and navigation platforms. We're not really coming from the real-time imaging standpoint like IRs and interventional cardiologists do. But you really need to stay dedicated and focus on learning the system and utilizing it to its maximum ability. Just to give you some context of things that I do before I start a case. Here we have a lung nodule in the right upper lobe, and I always think to myself before I start, where's this target going to be at 0 degrees? So if I just have the patient laying on a table and the X-ray goes straight through, where should the nodule potentially be? Then I think about where should the nodule be if I come from LAO and then also from RAO. And this gives me a sense of where I need to navigate before I start, but all my adjustments are based upon this type of thought process. And this is what I picked up from one of my IR buddies. Here's a video showing our planning. This is being done with the Philips Lung Suite software. And here, I'm gonna be switching the windows over soon, but I'm circling our target. And the software actually automatically segments out the nodule in axial, coronal, and sagittal planes. And this was done right after a CT scan was performed. And now, when we switch over to fluoro, this target will be persistent on the screen, as you'll see on the next slide here, where now, this is after I've navigated there, but I put out an instrument and you can see that my needle is going through the target. And as we rotate and sweep 90 degrees, my needle stays within the target completely. And that's what proves that I'm actually within the target. Now, after I achieve this on fluoroscopy, I will do another CT spin to confirm that my needle is actually within the target. That's why, because as you can see, this target is only about 8 millimeters. So we can't, just go off of this single sweep that we're done. I want to use a CT scan to really confirm that I finished everything. But this is a journey, and it's something that you really need to kind of, believe in a system, understand that there's nothing that's more of a gold standard than a cone beam CT scanner. Robots, all these navigation platforms have all been validated on cone beam CT. So you really want to use the machine to its full ability and stay dedicated to the process. I can't really, overstate how challenging the first 10 cases are. But after you make it through that, things really start to pick up, and you really start gaining confidence in going after targets that you wouldn't have gone after earlier. From my 10 to 50 cases, I really started expanding the target selection. So earlier I was going after masses or kind of straightforward chip shot targets. Then I started saying, okay, let me go after kind of some smaller targets. I started, distancing myself from using the super dimension platform just because it was an extra piece of equipment, extra setup. And I started becoming more interested in other tools, other catheters and wires to see what can this get me there. So for example, we stopped using the super dimension platform, but I continued using the super dimension catheters because I liked the bend on them, and it was allowing me to navigate out into the lungs, pretty easily. And I started exploring the augmented fluoroscopy a lot more, and really feeling like, okay, using that capability to really help me navigate as opposed to using just navigation. As I was mentioning, at the top left, I was using the super dimension catheter quite frequently. I commonly use an MP190 bronchoscope, the ultra slim, but we use whatever scope is going to be best for the case. So if it's a TH190, it's a TH190. If it's a P190, it's a P190. We've actually done EBUS linear cases where I would blindly stick my needle, 3 to 4 centimeters through the trachea into a lung nodule that was surrounded by lung tissue in the upper lobes. I commonly use the Olympus ParaView, but whatever needle is going to be good for the case is what I choose. And I'll even use wires at times to kind of help stabilize my scope. and such. So really, I'm trying to opening my eyes and my world to other tools, similar to how IRs and interventional cardiologists do. Now I'm just going to talk about a couple of cases here. You can see this is a quite challenging small target here that's about 7 to 8 millimeters here in the right upper lobe, a spiculated nodule with some ground glass surrounding it. And here's a case where our needle's kind of going into it, and we were able to diagnose an adenocarcinoma with that. This is a case that honestly, I think many people with superdimension would have passed up on, or if they went after, they just wouldn't have successfully diagnosed it. Here's a cavitary lung nodule that had a negative BAL, but it had a PET positive wall. And so we actually decided to go biopsy that inferior wall of the right upper lobe cavitary actual nodule. And you can see my needle in the axial view is facing right at us, so I'm dead center in it. And then on a coronal, you can see that I'm indenting the inferior wall, which was actually the PET positive portion. And this ended up being a Mycobacterium xenopi diagnosis that I got on a forceps and the needle and the BAL. And we actually did an intracavitary BAL because eventually in the case, I placed the needle on the inside, put a few mLs of saline there, and then I washed it out. Here's a case where we did bilateral lung nodules. So the patient had a smaller right lung nodule and then a left lung mass. The mass ended up being squamous cell carcinoma, and the nodule ended up being adenocarcinoma. So this is a case where we did both sides. And the reason I was comfortable doing both sides is because I had a CT scanner, so I could see if there was a pneumothorax or not after I did the first side. And then once we successfully did that side, we did a CT scan to verify that there's no pneumo. Then I went to the contralateral side. Here's a really kind of small ground glass lung nodule that you can see in the right upper lobe. You can see that my cryoprobe is located right on the edge there, and we were able to diagnose a well-differentiated adenocarcinoma. Once again, this is another target that would have been very challenging to get, but because I can confirm tool and lesion, I felt comfortable going after and successfully getting the diagnosis. This is just showing a case where there was basically a right lower lobe lung nodule. In the top left, you can see our needle's right close to the center of the lesion. And then on the right-hand side, it's basically a 3D reconstruction that's done by the Lung Suite software that kind of shows you your instrument and your needle orientation that you can rotate around 360 degrees and see from different angles. And in the bottom left-hand side, we left a fiducial marker in place for our radiation colleagues. This ended up being an adenocarcinoma. Here's another case that we did. You can see that along the heart border, there's a small lung nodule there that's about 9 to 10 millimeters that's spiculated. IR didn't want to biopsy this. It's not a case that you want to go blind bronchoscopically. So on the right-hand side, we did our case where you can see our needle is just going through the lung nodule. I was able to make sure that our needle couldn't go through and into the heart. And we were able to successfully diagnose this as well. And this ended up being a squamous cell carcinoma. This is, once again, a case that a lot of people would have passed up on, but now that I've done, almost 200 cases, it's a case that we feel very comfortable doing. And then, once you get to your 50 to 100 cases, now you start opening up your targets and start going after everything. That's what we ended up doing. We started focusing a lot more on procedural efficiency, like how can we do anesthesia quicker? How can we reduce the number of spins that we do? How can we, improve our navigation times? We started advertising our capability at this time, and looked at but keep in mind, make sure that you have enough availability and block time. You don't want to advertise it and not be able to deliver. And then what I really did with our team here is we studied our prior cone beam cases from our initial 50. Why did I miss when I missed? How did I successfully biopsy difficult targets? What were some tricks that I learned? Looking back at our tool and lesion percentage, and then what were our edge tool and lesion versus center tool and lesion? Because there's a lot of data emerging that if you're on the edge versus center, there could be a difference in your diagnostic yield. So really, it was more of a self-reflection time here of how can we do better? What have we learned now that we have a lot of experience? I get this question a lot, so I just wanted to insert a slide here, but about billing. The codes that we use for billing are 31627, which is navigational bronchoscopy, and we can bill for that because we're actually using a CT scan to segment out the nodule, similar to what we do with all other navigation platforms. 77012 is CT guidance for needle placement. And then 76377 is 3D rendering from an independent workstation. And we're using tomographic images. So these three codes can all be billed for doing a single cone beam CT case, in addition to all the instruments and other biopsies that you do. And really moving on to the future of cone beam CT, back in the day, we used to, have a chest X-ray that showed a pleural effusion. You'd have the patient sit on the edge of the bed. You'd, thump on their chest, try to find a dull spot, and then you stick a needle blindly. What ended up being developed? Ultrasound, right? And now every single thoracentesis pigtail that's done at all hospitals across the U.S., we use ultrasound. Why? Because it gives us image guidance, it gives us confidence, it gives us feedback on the safety and the success of doing thoracentesis. Same thing comes with when we used to do lymph node biopsies. This is before my time, but there were quite a few practitioners that were doing basically blind transbronchial aspirations of lymph nodes. This seems a little crazy now in the era of EBUS, but EBUS was developed, and we can see our needle under ultrasound guidance going into our target, and suddenly the yields went up, the safety went up, everything got, everything improved, because once again we got real-time image guidance, we got the confidence and the feedback of exactly what we were doing, and this has become the standard of care. And I think that peripheral lung nodule biopsies with bronchoscopy fall into a similar boat. We have, on the left-hand side, we have electromagnetic navigation, which was a major breakthrough in our field and really improved our diagnostic yields from 15 to 20% up to 65, 70%, but really kind of plateaued there, And radial EBUS has been a very great tool for all of us, because it gives us some of the ground truth of what we're going after, which is trying to find a solid density. But as we all know, there are some limitations with radial EBUS. It's not, it's more of a time checkpoint type of thing where you can go out there and make an assessment, but when you biopsy, it's kind of blind at that moment. But really, I think cone beam CT is very analogous to the other examples that I gave, in that the ultimate goal for bronchoscopic lung nodule biopsy is really to have tool and lesion. And with tool and lesion, you can have confidence that you're biopsying correctly, similar to all other biopsies that are done in the body currently, right? When you look at liver biopsies, kidney biopsies, CT-guided lung biopsies, all these other modalities have one thing in common. They have real-time image guidance. You can see your needle inside your target, and then you biopsy. In bronchoscopy, really because of the nature of the organ, the evolution of our field, and some of the safety limitations, we weren't fortunate to kind of have this, but we're entering that era where we can. And I really urge people to kind of focus on this, because ultimately, the future for our field is really going into, therapeutics. And to be successful at therapeutics, you're going to need to master cone beam CT and diagnostics. It's not like, okay, well, we're going to do diagnostics as we are, and when therapeutics come out, we'll just jump into it. There's going to be some time frame that's needed, some work to be put in, so that you can master learning cone beam CT and perfecting your technique, so that when time comes for therapeutics, whether it's ablation, injectables, peripheral brachytherapy, other modalities, that you've completely understood the entire game, feel very comfortable with the technology, and can really utilize and take get the most out of these rooms. So yeah, so that's where things are headed, but it's gonna run through cone beam CT. Just like to acknowledge a few people that have helped me along the way. But thank you. Any questions?
Thank you, Dr. Bedi, for that wonderful presentation. We do have a few questions that came in, so if you could please answer them. The first one is, how steep was the learning curve to get started using a cone beam CT system?
It's pretty steep. It's because a lot of us in our field are so reliant upon navigation platforms and visualization with our fiber optic scopes that we kind of trained in that environment, and we've practiced in that environment, and now we're saying, hey, you can use those things, but at the same time you need to start thinking about X-ray angles and imaging. It's almost like doing like a mini IR fellowship over the course of a few months. So it is a steep learning curve, but to be honest with you, I felt like it was one of the most fun times of my my training overall, because prior to cone beam CT, biopsying lung nodules bronchoscopically was kind of under the bucket of ignorance is bliss. You navigate to your target, you brush, needle, force it, and you leave. And if you have rows, you may get lucky and get some good feedback, but then you find out really on the diagnostic report on whether or not you get it. For me now, not to sound too childish, but every time I do a CT spin after I put my needle out, I get butterflies in my stomach, like, am I in or am I not in? And I get the gold standard truth after every spin to see if I successfully got to the nodule or not. And it's really made the actual procedure a lot more fun. It's actually one of the most fun procedures that I do now because of CT.
Thank you. The next question is, how important is the collaboration with different departments to get started with endobronchial biopsy and ablation?
It's very important. I think, first of all, when you want to get into cone beam CT, you are going to need to collaborate with other departments and garner their support, because at the end of the day, interventional pulmonology does not run cone beam rooms, doesn't run CT scanners. So we are kind of the outsiders that are trying to gain access. So you do need to collaborate. For us, we collaborated with interventional radiology and interventional cardiology to enter and to keep their support of our program. As far as ablation goes, you're going to need that support because we're also the newcomers to the field, and you don't want to, you have to kind of respect the boundaries that exist, but at the same time, do what's best for the patient. So I think garnering support of interventional radiology, thoracic surgeons, and such is very important, because ultimately you would like this modality to be pushed through your respective tumor boards. So yeah, I think it's very important to collaborate with others when you're going through this process.
Sure, we've got 2 more questions. Getting access to the technology is not always easy. What was your biggest learning?
So I think, I think this question is going to be really specific to what institution you're at. At Stanford, for us, me going through the process of doing a research project is what got me through the door and helped me get my first 10 cases done. And then after I finished the research project, I quickly just pivoted to clinical work and scheduling people freely. At other places, it may be a different route. For some places, I know, especially at community hospitals, there may be a room that's just kind of underutilized, and you may have an opportunity just to kind of just check and see, hey, can I get in? So I think you're gonna have to find your respective route. If you have a colleague that's in IR that you're really good, good friends with, that may be a route where you could partner with them to try to get into a room and have them join you for a couple cases. That would be an excellent way to get in. But I really think that you're gonna have to, be a little sneaky at times, learn the politics of what's going on. And that's why I'm saying studying the whole landscape. Find out how many cone beam scanners are at your institution. Also look at your peripheral, satellite sites as well, because there's a lot of centers where you may have an outpatient surgery center that's 2 miles down a road that has a room that's not being utilized. So find out which rooms are available, which companies have those rooms, what capabilities exist, look through the schedule, find out which room is the least utilized, and really put all your effort towards getting your foot through the door for that room.
Fabulous. And for the last question before we wrap up is, what is your expectation on patient volumes in the future for your practice?
Yeah, I mean, cone beam CT has exploded our volumes. Stanford was never a big center for navigation bronchoscopy. We've always hovered around something in a ballpark of 4 to 8 navigation cases per month total. So we were always low volume, and that was kind of our practice. Now that we're up and running with cone beam, we do approximately 24 cases a month now. So we do 6 per week. So we went from 4 to 8 to 24. So we exploded with our volume. Our referring doctors have been extremely happy with the access that we've had to reaching these really difficult lung nodules. I wasn't able to show in the slide here, but this last Friday I successfully biopsied a 5.6 millimeter lung nodule that ended up being squamous cell carcinoma. That's a target that people wouldn't have gone after, but the lung nodule was growing every CT scan. And one of my colleagues said, "Hey, Harmeet, you've gone after really small targets. Would you try going after this one?" I'm like, "Sure, I could try." But when you have a CT scanner, you always find the gold standard truth at that time. You get to see where your instrument is. You get to see if you're in the target or not. So you can chase a lot more. So we went from going after generous targets that were 15 to 25 millimeter lung nodules now to things that are 7 millimeters and greater. So we increased our volume by going after targets that weren't necessarily being biopsied. And now with our success, we've actually been able to take targets that that were being sent to IR that our colleagues are now like, hey, let's just send them to IP now. So it's been a huge volume boost for us, and I expect any cone beam CT program to actually blossom like that.
Well, we thank you so much on behalf of the Society for Advanced Bronchoscopy and your participation in today's talk. It was a wonderful presentation, and thank you everyone for joining.
Thank you.